So we start with the next module, that is combined hormonal contraception and FSRH guideline. Okay, this topic is going to be very important from the examination point of view. So let us see about combined hormonal contraceptive. Okay, what does this combined hormonal contraceptive contain? They contain estrogen and the progesterone. Estrogen will be mostly ethinyl estradiol, and progesterone can be any one of this. That it may be levonorgestrel, it may be norethistérone, it may be other type of progesterone also. Okay, but normally CSC containing ethinyl estradiol can be started by medically eligible women up to and including 5 days of natural menstrual cycle without the need of additional contraceptive protection. So what is the ideal time of starting these oral contraceptive? It should be started within 5 days of the first 5 days of the natural menstrual cycle.
This is a reminder.
Alexa, stop. So it should be stopped within started within the first 5 days of the natural menstrual cycle without need for any additional contraceptive protection. You have a combined hormonal contraception which contains ethinyl estradiol. You can start at any time of the cycle for a medically eligible woman, provided if it is reasonably certain that the lady is not pregnant and a high sensitivity urine pregnancy test is negative. Okay, even if there is a risk of pregnancy from the unprotected sexual intercourse in the last 21 days, okay, a follow-up high sensitivity urine pregnancy test is required 21 days after the last UPC. So what here they are saying, what is the ideal time? You should start within first 5 days of the natural menstrual cycle. Second is, if it is to be started at any time of the menstrual cycle, in that particular case, you should be reasonably certain that the lady is not pregnant. And second, the high sensitivity urine pregnancy test should be negative. Okay. And still there is a risk. Suppose you start on day 13 or day 14 of the cycle, but there is a risk. So you have to do a follow-up urine pregnancy test after 21 days after the last unprotected sexual intercourse. Okay, I hope this particular concept is clear to you. What is the ideal time? Up to 5 days of the cycle. At any time, if you do it, then we should be reasonably sure that the lady is not pregnant. Second, another thing, one more thing, that she should use the additional contraceptive precaution for another 7 days. Okay, so these two things are important. Okay, most evidence suggests no association between the body mass index and the effectiveness of combined oral contraceptive. Limited evidence suggests a possible reduction in the patch effectiveness for if the weight is more than 90 kg. Women who have had bariatric surgery should be advised that effectiveness of combined oral contraceptive could be reduced. Okay, so per se, BMI does not have any effect on the oral contraceptive. But if the combined hormonal contraceptive can be oral, it can be vaginal ring, or it can be transdermal patch also. But when you are using the patch in a lady who is more than 90 kg, there can be reduction in the efficacy of the patch. Okay. Otherwise, oral contraceptives, it has got no association with the BMI. Okay. Women who had bariatric surgery, if she has undergone bariatric surgery, then combined oral contraceptive, the efficacy may be reduced. Okay, because the absorption may get hampered. Women using enzyme-inducing drugs should be informed that the contraceptive effectiveness of CSCs could be reduced during the enzyme inducer and for 28 days after stopping. This concept is going to be very, very important from examination point of view. If the lady is on enzyme-inducing drug, then she should use effective contraception. Okay, so if she is on oral contraceptive oral contraceptive, then we need to tell her that the effect of this combined hormonal contraceptive may be reduced, and for the duration of the use of the drug and 28 days after stopping the drug. Okay, so when woman using the enzyme inducing drug should be offered a reliable contraceptive method that is unaffected by the enzyme inducer. So women taking lamotrigine should be advised that CSC may interact with lamotrigine, and this result in reduced seizure control or lamotrigine toxicity. The risk of using CSC could outweigh the benefits. Again, another anti-epileptic drug, that is lamotrigine. Okay, this lamotrigine is not an enzyme inducer, but for some unknown mechanism, this has been observed that combined oral contraceptive and lamotrigine, there is a drug interaction, and the efficacy of the lamotrigine is reduced during the use of the combined hormonal contraceptive, and when there is a uh, pill-free period or the hormone-free interval during which there are high levels of lamotrigine that will lead to the toxicity of the lamotrigine. So during the use, there may be even the reduction of the lamotrigine activity also, and the seizure control may also be reduced. So these are the points, especially with the lamotrigine, they are asking very frequently. You should remember. Okay. Next is the progesterone receptor modulators. Okay, like UPA. Okay, ulipristal acetate. Okay, which is used for emergency contraception. Okay. So clinical recommendation: women should be advised to wait for 5 days after taking ulipristal acetate for emergency contraception before starting CSC. So what happens? Most of the ladies come for emergency contraception. Then in oral emergency contraception, we have two options. One is a LNG oral, and second UPAEC, that is ulipristal acetate emergency contraception. So for ulipristal acetate, we have to remember that we cannot start oral contraceptive immediately along with the UPAEC. Okay, when ulipristal acetate is used for emergency contraception, you have to wait for 5 days before starting the oral contraceptive. Okay, and for oral contraceptive to get its effect, so it takes 7 days for inhibition of the ovulation. So there should be additional contraceptive for the initial 5 days and the next 7 days. Okay. So women should be made aware that they must use condoms reliably or abstain from sex during the 5 days waiting, and then until their contraceptive method is effective. I hope this particular concept is very clear. What is the effect of UPA-EC and the combined hormonal contraceptive? Okay, very, very clear, and this can be asked in the examination. Then use of CSC for contraception may also be associated with non-contraceptive health benefits. Okay, so when lady is taking this combined hormonal contraception for contraceptive purpose, she can have additional benefits, like there can be reduction in the heavy menstrual bleeding or menstrual pain. There can be improvement in the acne. Okay, so use of CSC may be beneficial for women with premenstrual syndrome, and it can also reduce the risk of recurrence of endometriosis after surgical management. CSC can be used for the management of acne, hirsutism, menstrual irregularities associated with polycystic ovarian syndrome. Then CSC use is associated with a significant reduction in the endometrial and ovarian cancer that increases with the duration of CSC use and persists for many years. Even the CSCs are stopped. Okay, so which cancers it has got a protective role? Endometrial cancer and the ovarian cancer. Okay, and it has also got a slightly reduced risk of colorectal cancer. So protection against three cancers: endometrial cancer, ovarian cancer, and the colorectal cancer. Okay, and apart from that, menstrual complaints such as dysmenorrhea, menorrhagia, they will be reduced. Endometriosis has got a beneficial effect, and other PCOS related like acne, hirsutism. Okay, so these are the non-contraceptive benefits of the oral contraceptive. Then what are the health risks? Okay, in the health risk, certain things you should remember. One is a venous thromboembolism. Okay, second is a myocardial infarction and the ischemic stroke. Okay, and third thing, increased risk of breast cancer. So in the malignancy, breast cancer, you should remember. Also, slightly increased risk of cervical cancer also has been noted. But it once you stop the use, then it reduces, and after 10 years, there is no effect, no longer increased risk. Okay, so we will go one by one. One is a venous thromboembolism. Okay, so VTE risk. So current use of CSC is associated with increased risk of VTE. Some CSC formulations, and this is VTE is associated with the which component of the CHC combined hormone? It is the progesterone, that is dependent on the type of progesterone and the dose of the estrogen. So these are the two things which will have the effect on the VTE. Okay, it is the dose of the estrogen and the type of progesterone. Okay, so current use of CSC is associated with a small increase of myocardial infarction in the ischemic stroke that appears to be greater with higher doses of estrogen in the COC. Okay, so for VT, mainly it is the progesterone type and the estrogen dose. For myocardial infarction and the ischemic stroke, it is only the estrogen that is responsible. Okay, women should be informed that the current use of CSC is associated with increased risk of myocardial infarction and the ischemic stroke, but that these events are still extremely uncommon in CSC users, and use of CSC by women with significant additional risk factors for arterial disease should be strongly cautioned or avoided. So if she has got any history of arterial disease, then the use of oral contraceptive to be avoided. Okay, combined hormonal contraceptive to be avoided. Women should be advised that current use of CSC is associated with a small increased risk of breast cancer, which reduces with the time after stopping the CSC. So it has got a protective effect and it has got a adverse effect also. So protective, what we have seen: endometrial cancer, ovarian cancer, and third one was a colorectal cancer. And it has got its positive associated with the breast cancer and also with the very small risk of cervical cancer. However, once you stop it, this risk reduces. Okay, that is what the guidelines says. Okay, now when you are starting the combined hormonal contraceptive, what are the things which we need to check? Okay, so what does the clinical recommendation say? Assessment of medical eligibility for combined hormonal contraceptive should include medical conditions, lifestyle factors, and the family history. Okay, the drug history you have to take, and drug history related questions are very frequently asked. Any prescribed or non-prescribed drug that could affect the effectiveness of the contraceptive, or the contraceptive can affect the efficacy of the drug. Okay, so a recent accurate blood pressure recording should be documented for all women prior to first CSA prescription. BMI should be documented for all women prior to CSA. So two things only you have to mention. One is the blood pressure and second is the BMI. Okay, so a good history. The history has to include the drug history, and second, and the drug history should also include any over the counter drug if she is taking. Then another thing is that we have to need general examination. One is a blood pressure and second is a BMI. So these two things you have to document. Then pelvic examination, screening for cervical screening, breast examination, testing for thrombophilia, hyperlipidemia, diabetes, liver function, they are not routinely required. Okay, so when this they may ask you this in the following is required before starting the oral contraceptive. So only blood pressure and the BMI. A good history, blood pressure, BMI. Okay. The rest of the things like breast examination, then cervical screening, other testing for thrombophilia, hyperlipidemia, diabetes, liver function tests, they are not routinely required. Okay. So, COC containing less than 30 micrograms of ethinyl estradiol with levonorgestrel or norethistera. Okay, women should be advised that routine annual review for the contraception is recommended. So, we will be giving her 12 packs of the oral contraceptive and call her for review after 12 cycles. Okay, women trekking to high altitude. So, suppose if she is traveling to high altitude above 4,500 meters or 14,500 feet for more than 1 week, she needs to switch to the safer alternative contraceptive. Okay, so here the change of contraceptive is required, and women should be advised to stop CHC and to switch to alternative contraceptive method at least 4 weeks before planning a major surgery or expected period of limited mobility. Suppose she is undergoing some major surgery where there is a immobility, then these contraceptive pills are to be stopped for 4 weeks prior to the surgery, prior to the planned surgery. This is important, especially in part 3 of MRCOG, where they have got a clinical scenario where the patient is expected to undergo surgery. And at that time, we need to advise that she will be stopping this for 4 weeks. Okay. So even they can ask you in the SB also. CSC can be used by medically eligible women for contraception until the age of 50 years. So what is the duration? So from the young age to the age of 50 years, she can use. CSC can be considered for the use by medically eligible women until the age of 50 as an alternative to HRT for relief of menopausal symptoms and prevention of loss of bone mineral density as well as contraception. So it can also be used as a HRT along with contraception. CSC is highly user dependent. So what we have seen about the failure rate, it is low, less than 1%. It is practically 0.3% when used correctly. Okay, but if there is a typical use, it is 9%. Okay, for women who have can lead to the unplanned pregnancies in the first year of CS use. Effectiveness could also be affected by the drug interactions, malabsorption, and CTP can also, that is the combined transdermal patch. CTP is a patch. Okay, and that patch is has got a relation with the BMI. So if the weight is more than 90, the CTP will be less effective, while oral contraceptive pills does not have any relation with the BMI. Okay, that you should remember. Okay, now the progesterone, again they are asking the generations of the progesterone in the examination for the part 1 candidates. The progesterones that are components of the CSC are sometimes grouped by generation according to the time they were first marketed as constituents of COCs. Okay, so in first generation you have norethistron, that is net. Okay, NET, norethistron is the first generation, LNG is the second generation, then third generation you have disogestrel, gestodini, and norgestimate. Okay, disogestrel, gestodini, and norgestimate. While the newer ones, they are the drospirenol, dinogest, and nomogestrel acetate. Okay, NOMAC, nomogestrel acetate, drospirenol, dinogest, and nomogestrel acetate. Okay, see this norgestimate sometimes it is classified as a second generation because there is an active metabolite of this is a leonorgestrel. Okay, so norlegestimate is a metabolite of norgestimate, and etanogestrel is the derivative of the disogestrel. Okay, so here in the third generation you have disogestrel and norgestimate. So norgestimate is a this is the final product, but it gets metabolized into the active metabolite, that is norlegestromine. Okay, and etanogestrel is the active metabolite of disogestrel. Okay, sometimes they can ask you the active metabolite of disogestrel, that is etanogestrel, and norgestimate active metabolite is a norlegestromine. Okay, and this also you should remember cosiprandol, which contains 35 micrograms of ethinyl estradiol along with the cyproterone acetate, that is an anti-androgen, and it is indicated for management of moderate to severe acne and hirsutism. So this also they have asked as a SBA in the past, which oral contraceptives are beneficial in treatment of severe acne and hirsutism. It is a cosiprandol, that is 35 micrograms of ethinyl estradiol along with cyproterone acetate. Okay, so women using cosiprandol for these indications do not require additional contraception. So if she is taking this for the treatment of acne, no additional contraception is required. Okay, so what methods of CSC are available in the UK? As I have already mentioned, the combined hormonal, it can be given orally, it can be given in a transdermal patch format, or it can be given in form of vaginal ring. Okay, so under the heading of CHC, that is combined hormonal contraceptive, you have COC, CTP, and CVR. Okay, COC, CTP, and CVR. So COC is combined oral contraceptive, CTP is combined transdermal patch, and CVR is a combined vaginal ring. So CTP, that will have a ethinyl estradiol 33.9% along with norlegestromine. Then CVR has got etinogestrel as a progesterone along with ethinyl estradiol. Okay, so withdrawal bleeding may be heavy, painful, or simply unwanted. So what happens normally, there is a 3 weeks on and 1 week off. Whatever you give COC daily one for 21 days, and there is a 1 week off. You give transdermal patch. Patch is for 1 week. Okay, the patch is for 1 week. So you give 3 patches for 21 days, and there is a 1 week off. You give vaginal ring. Vaginal ring is once for 21 days. Okay, so give single ring and off for 1 week, then start the new ring. That is how you give this combined hormone contraceptive normal. Okay, so there are other methods also, that also we will discuss. So withdrawal, what happens after the use of the contraceptive, there may be withdrawal bleeding that may be heavy, painful, or simply unwanted. Most of the side effects happen during the hormone free interval, that 1 week duration, during which the symptoms of headache and mood change can also be there. And not only that, this hormone free interval, HFI is hormone free interval. Okay, ovarian suppression is reduced, and that follicular development can happen during the HFI, and particularly with the COC containing low doses of ethinyl estradiol. So if the patient is making certain errors in the pill taking around the HFI, that will result into the ovulation and potential risk of pregnancy. So that is why HFI is having the HFI especially and if the patient is not taking it in a proper way, it can lead to the failure. Okay, so please remember the importance of the hormone free interval and the compliance. Okay, now combined oral contraceptive, they are designed in the UK for 28 days cycle, so they are to be taken for 21 days consecutively for active pills, followed by 7 days hormone free interval. Okay, so prior to starting the next pack, that is why they will be taking 21 days consecutively daily active pills, followed by 7 days gap. Okay, and then new pack will be started. The first 7 pills inhibit the ovulation and the remaining 14 pills maintain the ovulation. This line is going to be very, very important. You please understand, for the these oral contraceptive pills, they act by inhibiting the ovulation. But to inhibit the ovulation, what is the mechanism? The oral contraceptive pills should be taken continuously for the first 7 days. Once the pills are taken for the first 7 days, the ovulation is inhibited for the next week. Okay, so first week, if it is started within the first 5 days of the cycle, there is no need of the additional contraceptive. But if it is started after the 5 days, then she has to use the additional contraceptive for the 7 days, because the ovulation can happen because of that hormone free interval. Okay, so the first 7 pills inhibit the ovulation, and remaining 14 pills will maintain the ovulation. So first 7 days they will inhibit the ovulation. If you continue with the next 7 and plus 7, then it will maintain the anovulatory state. Okay, what happens to the combined transdermal patch? So one patch is applied to the skin and one for 7 days to suppress the ovulation. Thereafter, the patch is replaced. So as I mentioned, the patch is for 1 week. So it is applied to the arm or the belly, and it is kept for 1 week. So it will suppress the ovulation. Then after, the patch is replaced on a weekly basis for next 2 weeks. The fourth week is a patch free, and that allows the withdrawal bleed. A new patch is then applied after the 7 patch free days. Okay. Now, when you have a vaginal ring, the ring is for 21 days. So one ring is inserted in the vagina, and it is left in place continuously for 21 days. After a ring free interval of 7 days, there is a withdrawal bleeding, and then new ring is inserted. So I hope you have understood how these are to be taken. Oral pills daily for 21 days, followed by 7 days of hormone free interval. If it is a vaginal ring, it is for 21 days. If it is a transdermal patch, it is for 7 days. So 3 packs followed by 1 week of hormone free interval. Okay, so that is the way it is to be taken. Now, most of the side effects are mainly because of this hormone free interval, and the risk of failure is also there because of this hormone free interval and irregular taking of the pill. So how to tackle with this? So this we have seen standard use 21 days, that is 21 days active pills, or one ring, and or 3 patches. Okay, and hormone free interval of 7 days. But this can further be modified in various forms. Okay, so what you do, you keep the same schedule but reduce the HFI to 4 days. So after 4 days, she will start the new cycle. Okay, so she will take it pills for 21 days and HFI of 4 days, and then new pack will be started. Same thing about the ring patches. She will take for 3 weeks, 4 days of HFI instead of 7, and then she will start the new patch. Okay, so this is another modification. Then another what she can do, she can have an extended use tricycling. So instead of 21 days, that is 3 weeks, she will take 9 weeks. Okay, so 21 active pills for 3 months. Okay, or 3 rings she can use, or the 9 patches, and after that she may take the HFI of either 4 days or 7 days. Okay, so this is another modification. Next is a flexible extended use. Okay, she will take the continuous pill for 21 days, or patches or rings, until there is a breakthrough bleeding which occurs for 3 to 4 days. Then she'll take a 4 days of HFI and start with. So continuous use more than 21 days. So go on taking the pills till she gets the breakthrough bleeding, give the HFI of 4 days and start the new. So that is called as flexible extended use. Okay. Another protocol is a continuous use. That is a continuous use of active pills patches without any HFI. So these are the standard and tailored regimens for the use of combined hormonal contraception. Okay. I hope you have understood this. This is the standard one, and these are the tailored ones. Okay. Now, when the CSC can be started, CSC containing ethinyl estradiol can be started by medically eligible women for a bit up to 5 days of the natural menstrual cycle without the need for additional contraception. This we have seen last. Okay. Now, what are the criteria to say that the she is uh, not pregnant or reasonably excluding the pregnancy? Suppose you want to start the oral contraceptive pills at any time of the cycle. In that particular case, what are the things which are important? She should use the 7 days of additional contraception, and we should be sure that she is reasonably we are excluding the pregnancy. If these two facts are there, in that particular case, we can start on any days of the cycle. Okay, first is a 7 days of additional contraception, and we should be sure that she is reasonably we should be reasonably sure that she is not pregnant. Now, how we can do this? So one thing is that she has not had any sexual intercourse since the start of the normal menstrual period, or after the childbirth or abortion or miscarriage or ectopic pregnancy treatment or the uterine evacuation. So that is one way of excluding the pregnancy, that there is no intercourse after the end of the cycle or after the abortion or the childbirth, or that is one. Second, she has been correctly or consistently using some reliable method of contraception. That is another. Any method she is using, okay, then also we can say that we are excluding the pregnancy. Next is, if she is within first 5 days of the natural cycle, then she is within 21 days of the postpartum if she is not breastfeeding. If she is fully breastfeeding and amenorrheic, then it is less than 6 months postpartum. Or she is within the first 5 days of the abortion, miscarriage, ectopic pregnancy, or uterine evacuation for GTD. In that particular case, we are reasonably excluding the pregnancy. Or she has not had intercourse for more than 21 days and has a negative high sensitivity urine pregnancy test. Okay, then we can say that we are excluding the pregnancy. So these are the points where we can exclude the pregnancy. Okay. Now let's see starting the combined hormonal contraception and requirement of additional contraceptive precautions. Okay. Now when we are starting the combined hormonal contraception, what is the need for additional contraceptive? If it is started within first 5 days of the cycle, there is no need, because that is the right time to start. So let us see when there is a need for requirement of the 7 days of additional contraceptive, because what we have seen, the oral contraceptive pills take 7 days to inhibit the ovulation. That is why there is a need for 7 days of additional contraceptive. Okay, so women having natural cycle, if it is started within first 5 days, then there is no need of the uh, additional contraceptive. If it is started at any time of the cycle, yes, then it is required. If the lady is amenorrheic, okay, and at the time, if it is reasonably certain that she is not pregnant and HSUPT is negative, then we definitely advise this. If we are starting at any time of the cycle, then we should take the advise the 7 days of additional contraceptive. Okay, after LNG, if we are using LNG EC, that is the levonorgestrel emergency contraception, then we have to use additional 7 days. Okay, but it can be given immediately. Another thing what we have seen, UPAEC, that is ulipristal acetate, it cannot be used simultaneously. While along with the LNG, this can be used simultaneously. If we are using with UPA, that is ulipristal acetate, we have to wait for 5 days after the UPAEC, and we have to use additional 7 days contraception. So 5 days plus 7 days additional contraception is required. After the childbirth, if she is feeding, then from 6 weeks we can use, and additional 7 days of contraception is required. After childbirth, without additional risk for VTE, and from 3 weeks following the childbirth, yes, it is required. And if she has got a with additional risk, then from the 6 weeks following, we can she need to use 7 days of additional contraception. So these are the different conditions, and we need to advise 7 days of the additional contraception. Okay, so after the abortion and miscarriage, up to 5 days there is no need, but if it is started after 5 days, then additional 7 days of contraception is required. So that concept you should remember. Now if she is taking the hormonal contraceptive, okay, but she wants to change it to the combined hormonal contraceptive, switching from one hormonal contraceptive to other hormonal contraceptive. Okay, suppose she is taking vaginal ring and wants to shift to oral. Okay, or either way, then what is the way? Okay, so if she is switching from one type of combined hormonal contraceptive to another combined hormonal contraceptive, then it should be started on the day after the last active COC. So whatever the hormonal method, if she is using vaginal ring, once the it is removed, immediately you have to start the COC. Okay, if she wants to start COC, if a hormone free interval is taken, then need for additional precautions and emergency contraception should be assessed on an individual basis, taking account for the correct use of before HFI. So if she is shifting from one hormonal contraceptive to another hormonal contraceptive, it should be done immediately without the intervening of the HFI. That you have to remember. Then if she is shifting from progesterone only pill, that is traditional POP, we know that traditional POP takes 48 hours or the 2 days for the action. So it can be started immediately if the POP has been used consistently. So traditional, but CSC takes 7 days for the ovulation inhibition. So after the traditional POP, if the CSC is to be started, then she need to use 7 days of additional precaution. Okay. Now, if we are using newer type of progesterone method, that is desogestrel, injectable or implant. Okay. And from there, she is shifting to the CSC. Okay. In that, these are the methods. These are the methods where they act by anovulation, while traditional POPs, they act by increasing the thickness of the mucus. Okay. So here there is action on the cervical mucus, which is short lasting. Okay. While these methods, that is digital injectables and implants, here they are making the cycles anovulatory. So if she is taking these, then there is no need of additional contraception. That is what is the difference between the traditional POP and the other methods of oral POPs. Okay. So these are the newer ways of progesterone anovulatory methods. With that, if she is shifting to CSC, there is no need of additional 7 days of contraception. Now, if she is on LNG and she wants to shift to CSC, then 7 days of additional contraception is required. If there has been unprotected sexual intercourse in the last 7 days, then the LNG should be retained for 7 days. So she should continue to use LNG for 7 days. So she will start CSC, but she will keep the LNG for additional 7 days. Okay. Now, the next is the switching from non-hormonal contraceptive method to combined hormonal. So what we have seen, from one hormonal to another hormonal up till now. Now from non-hormonal, that is either from barrier contraceptive or from the copper IUD. Okay. From non-hormonal contraceptive method to combined hormonal contraceptive. Suppose if she is using copper IUD and now she wants to shift to CSC, then up to 5 days, it can be done without any additional contraceptive. But if it is done after 5 days, then additional 7 days of contraception is must. Okay, is this clear to you? Copper IUD, if within first 5 days, then there is no need. But after 5 days, yes, 7 days of additional contraception is required. Then non-hormonal method. Okay, apart from copper T, then she is shifting to CSC. Up to and 5 days of the cycle, no need. But at any time of the cycle, 7 days of additional contraception is required. Okay, and this chart is going to be very, very important from the examination point of view. This chart will tell you the failure rate of all contraceptive, and anyone they can ask you. Okay, so this chart is very, very important. This is the perfect use and this is the typical use. So if no method is used, then failure rate is around 85%. Fertility awareness method with a perfect use, it is 5%, while a typical use it is 24%. Female diaphragm we have seen it is 6 and 12. Male condom we have seen 2 and 18. Combined hormonal pills and progesterone only pills. Remember, this is same, 0.3, 0.3 and 9. That is how you can remember. Perfect is 0.3, less than 1%. That is what we have discussed. It is 0.3, 0.3 for COC as well as POP, and with typical use it is 9. Progesterone only injectable, it is 0.2 with perfect use, and typical use it is 6. Copper IUD 0.6 and 0.8. Then LNG IUS, it is zero point 0.2 and zero point 0.2. And the list is a progesterone only implant, that is 0.05. Okay. So progesterone only implant, that is almost 1 in 2000. Okay, 0.05. Okay. Then female sterilization is zero point 0.5 and zero point 0.5. Vasectomy is zero point 0.1 and 0.15. Okay. So these are the contraceptive failure rates of all contraceptives, and anyone can be asked in the examination. Then coming to the effect of the CSC and other conditions, like effect of vomiting and diarrhea. So vomiting and diarrhea, if she's taking the oral contraceptive, if vomiting is less than 3 hours after the pill, or the duration of the diarrhea is more than 24 hours, then we have to consider this as a missed pill. Okay. And if the symptoms are persistent, we have to advise non-oral contraceptive method. Now coming to the VTE risk. COC will increase the VTA risk by 3 to 3.5 times versus non-users. Okay. Absolute risk is around 5 to 12 per 10,000. Once they have asked this risk, okay, in the examination as SBA. So it is 5 to 12 per 10,000. Okay. While if she does not use any contraceptive, the natural risk of VT is around 2 per 10,000. So this gets increased to 3 to 3.5 times, approximately 5 to 12 per 10,000. About 1% of VT cases are fatal, and VT risk with different COCs. Now, low dose oral COCs, where ethinyl estradiol is less than 50 microgram, okay, then the CPA, disogestrel, gestodine, drospirenol. So if these progesterone, the newer progesterone use, the VT risk increases. Okay, so more the newer the progesterone, the higher is the risk of the VTE. North estimate COC similar to the LNG COC. Then VT incidence is around 2 per 10,000 that we have discussed. Okay. So that is what is the VTE and the COC. Okay. Then recommendations for additional contraception switching of other, like a suppose she is for additional contraceptive precautions when switching from combined hormonal contraceptive to other method. Now here the lady is using combined hormonal contraceptive, but she wants to switch to another CSC or another hormonal. What is to be done? This is what is shown in the chart. Okay. So that finishes this particular thing. Thank you.